This episode is for educational purposes only. It does not constitute legal advice or medical advice. The clinical scenarios described are composites drawn from publicly available malpractice litigation records and medical literature. No individual patient, physician, or institution is identified or intended to be identified. Consult your own legal counsel and clinical guidelines for decisions affecting patient care or legal matters. This is the cognitive autopsy, where we reconstruct the exact moment a diagnosis went wrong and identify the one thing that could have changed the outcome. I want to start this episode a little differently. I'm going to read you 2 entries from a medical chart. The patient is a 43-year-old man. He's in the emergency department with severe right leg pain. Entry 1, the triage note. 43-year-old male, known IV drug user, frequent flyer, here again for leg pain. States pain is 10 out of 10. Requesting IV pain medication. See prior visits for drug-seeking behavior. Entry 2, the physician note from the same visit. Patient is a known IV drug user with multiple prior visits for pain complaints. Agitated, demanding narcotics. Exam limited by patient's behavior. Impression, drug-seeking behavior. Discharge with ibuprofen and primary care follow-up. Now I'll tell you what is not in the chart. No pulse check, no skin temperature assessment, no capillary refill time, no color comparison between the 2 legs, no ankle brachial index, no Doppler. This patient had an aortic valve vegetation, a mass of infected tissue on a heart valve that had been growing for weeks. A fragment broke off and lodged in the popliteal artery of his right leg. The blood supply to the limb was cut off. The leg was dying while the chart was documenting behavior.
We have all likely heard of this or read notes like this ourselves. Studies suggest that when you read a chart that says frequent flyer, drug-seeking, requesting narcotics, a cognitive switch flips. It happens before you walk into the room. You've already started forming an impression that has nothing to do with what's happening to the patient's leg. That's not a character flaw. That's a predictable cognitive response that's been measured and quantified. And today we're going to walk through exactly how it leads to a missed diagnosis that costs a limb and what you can do about it on your next shift. Today on the cognitive autopsy, critical limb ischemia dismissed as drug-seeking, the cognitive error cascade, the verdict landscape, and the 90-second exam that interrupts the entire chain.
Before we talk about cognitive errors and verdicts, we need to talk about the patient population at the center of this episode. Paul, set the clinical scene for us.
The patient in this scenario, and this is a composite drawn from the malpractice literature because these cases overwhelmingly settle under confidentiality, is a representative of a population every emergency physician and hospitalist sees regularly. A middle-aged patient with a history of intravenous drug use, multiple prior ED visits, a chart that carries labels from prior encounters, frequent flyer, drug-seeking, opiate abuse. Here's the clinical reality that matters. Intravenous drug use creates a specific set of medical risks that are directly relevant to what happened in this case. When you inject drugs intravenously over months or years, you exhaust the native venous system, superficial veins, sclerose, and thrombose. Patients move to deeper injection sites, groin, neck, sometimes directly into arteries. Every injection introduces organisms directly into the bloodstream. The result is a predictable cascade of infectious complications. Skin and soft tissue infections, cellulitis, abscess are the most common reason these patients are admitted, but the list extends far beyond the skin. Osteomyelitis, epidural abscess, like we covered that in our last episode, septic arthritis, bacteremia, and infective endocarditis.
How common is endocarditis in this population?
Infective endocarditis in persons who inject drugs now accounts for roughly 30% of all endocarditis cases in the United States. Hospitalizations for injection drug use-related endocarditis increased 12-fold between 2010 and 2015. The estimated risk compared to the general population is up to a 100-fold increase. The most common organism is Staphylococcus aureus, found in approximately 90% of cases. And here's the detail that connects directly to today's case. While injection drug use-associated endocarditis classically involves the right-sided heart valves, the tricuspid valve in particular, left-sided involvement is increasingly recognized. When the aortic valve is involved, or when there's a right-to-left shunt through a patent foramen ovale, vegetations can launch emboli into the systemic arterial circulation. That means the brain, the spleen, the kidneys, and the peripheral arteries of the extremities.
So a septic embolus from an aortic valve vegetation lodges in a leg artery and causes acute limb ischemia.
Exactly. And here's the thing. Critical limb ischemia is usually not subtle if you examine the leg. The findings are there. A cold foot, absent pulses, delayed capillary refill, color changes. But if you have already dismissed the patient's complaint based on the triage documentation or their reputation as a frequent flyer, you are less likely to engage in the kind of thorough exam that would reveal those findings. That is the danger here. The diagnostic trap is not that acute limb ischemia mimics other conditions. It can early on. But the real trap is bias. These patients are at increased risk of embolic phenomena, and we forget that when the chart has already told us the answer before we walk through the door.
Paul mentioned a cognitive switch that flips when you see certain words in the chart. Sarah, the research on provider stigma toward patients with substance use disorders has been quantified. Walk us through the data.
The evidence is extensive and consistent. A nationally representative study published in 2025 by Parrish and colleagues surveyed over 1,200 physicians and dentists and found that emergency medicine physicians had statistically significantly higher stigma scores toward patients with substance use disorders than primary care physicians. Stimulant use disorders carried the highest stigma among all conditions tested, higher than diabetes, higher than obesity. In a separate study, Mendiola and colleagues surveyed emergency physicians at Johns Hopkins and found that 54% somewhat agreed or higher that they prefer not to work with patients with substance use who have pain.
Does that stigma translate into measurable differences in care?
It does. Beckerleg and colleagues analyzed over 95,000 emergency department visits from the National Hospital Ambulatory Medical Care Survey between 2013 and 2018. Substance use-related visits were 38% less likely to receive imaging studies. The adjusted odds ratio was 0.62, statistically significant at p less than 0.0001.
I want to pause on that number, 38% less likely to receive imaging. For a diagnosis like acute limb ischemia, where the diagnosis depends entirely on vascular imaging, whether that's CT angiography, arterial duplex, or conventional angiography, a population-level reduction in imaging is a structural pathway to a missed diagnosis. You can't diagnose what you don't image.
There's a second finding that speaks directly to the diagnostic mechanism. Schmidt and colleagues conducted a randomized experiment in 2017 with 63 family practice residents. They found that diagnostic accuracy was significantly lower for patients described as difficult compared to neutral patients, 54% versus 64%. That's a 16% relative reduction in accuracy. And here's the critical detail. Time spent on each case was the same. The mechanism is not that physicians spend less time with these patients. The mechanism is impaired cognitive processing. The physician's attention shifts from the clinical findings to the source of negative affect, the patient's behavior, the drug-seeking label, the emotional burden of the encounter.
It is not always about effort, and most people are trying to do a good job. The cognitive impairment is happening below the level of awareness, and it's happening to physicians who believe they're giving the same quality of care. That is what makes this so difficult to address. You cannot correct for something you do not realize is happening.
The chart itself may also be playing a role. Sarah, there's research on how documentation language affects subsequent providers?
Gaudu and colleagues published a randomized controlled trial in 2018. 413 physicians in training were randomized to read chart notes about a patient with sickle cell disease written with either stigmatizing language, narcotic dependent, or neutral language. Exposure to stigmatizing language produced significantly more negative attitudes and significantly less aggressive pain management in the physicians who read those notes. The chart functioned as a vector for transmitting bias between clinicians. A large-scale study by Weiner and colleagues in 2023 used natural language processing on over 546,000 clinical notes for more than 30,000 patients with substance use disorders at Mass General Brigham. They found that 18.4% of notes contained stigmatizing language and that 61.6% of patients had at least one such note in their record.
So the chart note from a prior visit, drug-seeking, frequent flyer, manipulative, is still shaping the next provider's clinical reasoning before they've laid a hand on the patient. The label travels through the medical record like an infection. Each provider who reads it is a little less likely to look past it. With that foundation, let's reconstruct the cognitive error pathway. The research converges on a 5-step cascade that appears consistently across missed limb ischemia cases and the diagnostic error literature. Paul and Sarah walk us through it. Step 1. The label.
The error starts before the physician enters the room. At triage, the patient is categorized using a frame that excludes vascular pathology, drug-seeking, cellulitis, withdrawal, chronic pain. The electronic health record may flash a banner, frequent flyer, aberrant drug behavior. Lai and colleagues demonstrated this in a study of over 108,000 VA patients presenting with shortness of breath. When the triage note mentioned congestive heart failure, testing for pulmonary embolism was reduced by 1/3 and delayed by over 15 minutes. Even though the actual rate of PE was identical between groups, the label narrows the differential before clinical reasoning begins.
Step 2. Anchoring and premature closure.
The treating physician accepts the triage frame. The label feels sufficient. The social history provides a plausible explanation for the pain, withdrawal, drug-seeking behavior, and injection site complication. Premature closure follows. The diagnostic process stops. Graeber and colleagues established in their study of 100 internal medicine diagnostic errors that premature closure was the single most common cognitive error, contributing to 74% of cases where cognitive factors were involved. And this is where the physical exam fails. The vascular exam that would immediately reveal the limb threat, palpated pulses, skin temperature, capillary refill, color, is either omitted entirely or performed cursorily and documented as neurovascularly intact via template without actual palpation. The exam that was documented captures the patient's behavior. The exam that wasn't documented would have captured the patient's limb.
Step 3. The invisible gap.
This step is the hardest to detect in retrospective review because it manifests as an absence. It's the imaging study that was never ordered, the vascular consult that was never placed, the arterial Doppler that was never performed. The Becker leg data, 38% less likely to receive imaging, quantifies this gap at the population level. But in any individual chart, it simply looks like a provider who didn't think imaging was indicated. The chart doesn't say, I chose not to image this patient because of their substance use history. It just doesn't contain an imaging order.
And if imaging is ordered, it often follows the wrong pathway. This is one of the most consistent patterns in the malpractice cases. The clinician orders a venous duplex ultrasound to evaluate for deep vein thrombosis. The venous study comes back negative, and the case is closed. The provider interprets a negative venous study as ruling out the vascular complaint, but a venous ultrasound does not evaluate the arterial system. A negative venous Doppler does not exclude arterial occlusion. Every physician learned this distinction in training, but in the cognitive narrowing driven by anchoring, the distinction is lost. I want to share something from my own experience that illustrates exactly what we are talking about. Years ago, I was a rounding hospitalist, and a patient had been admitted overnight. The admitting diagnosis was intractable pain, and the ER note had these same themes: drug seeking. I'll be honest, I was slightly annoyed. I asked myself why this patient was admitted. When I went into her room, I asked what was different about this pain compared to her normal chronic pain. She said her left leg hurt and she could not get comfortable. She said that was new. Her chronic pain was back pain. I looked at the leg and it was cold and dusky blue. She was in the operating room with vascular surgery soon after. When I went back and reviewed the records more thoroughly, I saw the same pattern we are discussing here. Competent, well-intentioned medical providers, unknowingly biased, missed a critical piece of information from the patient and did not assess the leg. The one saving grace was that they admitted her for observation. And that is a win for the patient because it allowed another set of eyes to evaluate and assess. Sometimes the emergency department does not have to get the diagnosis right. Admitting for observation when something does not add up was the best option for this patient, and I believe her leg was ultimately salvaged. That was the more acute presentation, a true vascular emergency. It was that case that changed how I approach these patients. From that point forward, I have told every student and every colleague the same thing. Patients with substance use disorders can have organic medical emergencies. Patients with chronic pain can have acute pathology. You have to remove the noise of the label and objectively assess the patient in front of you without the bias.
Step 4. Diagnostic momentum.
When the patient returns, and they do return, or when they are handed off to another provider at shift change, the incorrect diagnosis carries forward unchallenged. Amano and colleagues published a simulation study in 2024 using 40 interns and 8 emergency department handoff scenarios. When the handoff included an incorrect working diagnosis, error rates jumped from 20.6% to 57.5%. Diagnostic momentum accounted for 52% of all errors. Whether the incorrect label appeared at the beginning or end of the handoff made no difference. The label itself was sufficient to override independent reasoning.
This is the multi-visit pattern you see in the malpractice cases. The patient comes back. The provider sees the prior note, cellulitis, drug-seeking, musculoskeletal pain. They accept it. They don't re-examine from first principles. One of the cases in the research involved 5 different providers across multiple care settings, all documenting intact pulses and neurovascularly intact in a limb that had arterial occlusion for over 2 weeks. The AHRQ Patient Safety Network published a case where a patient with complete superficial femoral artery occlusion was seen at 6 separate clinical visits over 2 months. Every provider anchored on the initial diagnosis of peripheral neuropathy.
Step 5. Irreversible ischemia.
Skeletal muscle tolerates 4 to 6 hours of complete ischemia before irreversible damage begins. Sensory nerves are affected first, then motor nerves, then the muscle itself. The ESVS 2020 guidelines classify acute limb ischemia by Rutherford category. Category 1 is viable with time for elective workup. Category 2 is threatened and requires emergent intervention within hours. Category 3 is irreversible. At Category 3, revascularization is not only futile, it's dangerous. Reperfusion of necrotic tissue releases potassium, myoglobin, and inflammatory mediators that can cause compartment syndrome, renal failure, and multi-organ failure. Amputation becomes the only safe option. Pismatzoglau and colleagues studied 280 patients with acute limb ischemia and found that 5% were initially misdiagnosed. The median delay to correct diagnosis in those patients was 38.8 days. Limb salvage dropped from 89% to 65%. Statistically significant at p-phi equals 0.02. Reintervention rates jumped from 18% to 65%. The biology does not negotiate. The limb does not wait for the cognitive error to be corrected.
Paul, you've described this cascade. Label, anchor, close, perpetuate, amputate. Where does it break?
At the physical exam, every time. That is the pivot point. The physical exam of the affected limb is where this error cascade either continues or stops. And if this is a chronic pain patient, the first question is simple. What is different about this pain? Ask the patient to tell you what has changed. Sort out whether this pain is the same complaint or something new. That question alone can redirect the entire encounter. Let me walk you through what I mean. The focused vascular exam for a patient presenting with acute limb pain takes about 90 seconds. It is not complicated. It does not require specialized equipment. It requires your hands and your eyes. Pulses. Palpate the dorsalis pedis and posterior tibial arteries. Document what you find. 2+ bilaterally, faint on the right, absent on the right. If you can't feel a pulse clearly, use a bedside Doppler. Every emergency department has one. 10 seconds for palpation, maybe another 30 seconds for Doppler if you need it. Temperature. Touch the foot. Compare it to the other side. Right foot cool to touch compared to left. 5 seconds. Color. Look at the foot. Pallor at the toes of the right foot. Model discoloration of the right forefoot. 3 seconds. Capillary refill. Press on the nail bed of the great toe. Count to 5. Capillary refill greater than 4 seconds on the right, less than 2 on the left. 5 seconds. Sensation. Can you feel this? Light touch at the dorsum and plantar surface of the foot. Sensation intact to light touch, or diminished over the dorsum of the right foot. 10 seconds. Motor. Wiggle your toes for me. Now pull your foot toward your shin. Dorsiflexion and plantar flexion intact, or weakness in dorsiflexion of the right foot. 10 seconds. That's it. That's the exam. 90 seconds. And those findings, in or their absence, determine whether the patient goes home with ibuprofen or goes to the CT scanner.
In the cases we're discussing, what would that exam have shown?
An absent or severely diminished pulse, a cool foot, pallor or mottling, delayed capillary refill, possibly diminished sensation. Those findings are unambiguous. There is no scenario in which a pulseless, cool, pale foot with delayed capillary refill is drug-seeking behavior. Those findings trigger an immediate workup for arterial occlusion. CT angiography, heparin anticoagulation, generic name unfractionated heparin. Vascular surgery consultation. And this is what the research drives home. In case after case, the litigation turns on this exam. There's a de-identified deposition transcript that was publicly posted, we don't know the full case, where the witness discusses the patient's drug-seeking behavior. In the same record, the patient's pedal pulses are documented as non-palpable. The chart had the answer. Someone documented the objective finding at some point, but the clinical frame, drug-seeking, overrode it.
let's talk about what the chart looks like when this exam is done versus when it isn't.
I'll give you two notes for the same patient presentation. Note 1, the one that gets written when the label wins. Patient is agitated, requesting narcotics, clock watching for next dose. Exam limited by behavior. History of IV drug use with multiple prior visits for pain complaints. Impression, drug-seeking behavior. Discharge with ibuprofen and primary care follow-up. Note 2, the one that gets written when you examine the limb. Right lower extremity, dorsalis pedis pulse not palpable, posterior tibial pulse not palpable. Foot cool to touch compared to contralateral limb. Capillary refill greater than 4 seconds at great toe. Mild pallor at toes. Sensation intact to light touch. Motor intact. Dorsiflexion and plantar flexion present. Concern for acute arterial insufficiency. CTA, right lower extremity, ordered stat. Vascular surgery consulted, heparin bolus initiated per protocol. The first note documents a person, the second documents a limb. One of those notes helps the patient, the other one hands the plaintiff attorney the ability to paint a very negative picture of the defendant, one that calls into question your credibility and your motivation as a physician, and we'll get to why in a moment.
Paul, is there a systematic way to interrupt the cascade before discharge?
There is, and it's been described in the diagnostic safety literature. Kasich and colleagues published a framework in 2019 called the diagnostic timeout. It's a deliberate pause before the disposition decision, analogous to the surgical timeout before an incision, where the clinician asks a specific question. For any patient with acute limb pain, the question is, have I considered and excluded arterial pathology? If the answer requires you to check a pulse you haven't checked yet, the answer is no. If the answer is, I ordered a venous ultrasound and it was negative, the answer is still no, because a venous study does not evaluate the arterial system. The diagnostic timeout costs 30 seconds of thought. Crossgary's work on cognitive forcing strategies, deliberate, structured checks designed to counter anchoring and premature closure, supports the effectiveness of this approach. It's not about slowing down your entire workflow. It's about inserting a single structured question at the highest risk decision point, the moment before the patient leaves your department. And the return precautions need to match. If you're considering arterial pathology, the return precautions should be specific to ischemia progression, worsening pain, new numbness or weakness, coolness, color change, inability to bear weight, not return if symptoms worsen. Return if these specific things happen.
Sarah, let's turn to the courtroom. What does the litigation landscape look like for missed limb ischemia?
The verdicts in missed limb ischemia cases are among the highest in medical malpractice. I'll walk through the publicly documented cases. Luppold versus Hanlon, Massachusetts, 2023, affirmed by the Massachusetts Supreme Judicial Court in January 2025. A 35-year-old man presented to the emergency department with back pain and a cold, purple left foot. The triage nurse asked if he had stuck his foot in a snowbank. The physician assistant did not read the triage note. He diagnosed sciatica and discharged the patient. 6 days later, the patient returned with severe ankle pain. A nurse practitioner again diagnosed sciatica and discharged without vascular imaging. 10 days after the initial presentation, a vascular surgeon at another facility found complete arterial occlusion. Above-knee amputation followed. The jury returned a verdict of $20 million, which increased to $28.8 million with prejudgment interest. Expert testimony established that revascularization at either visit would more likely than not have saved the limb.
2 missed opportunities. Same diagnosis both times.
The cognitive errors are textbook. Anchoring on a documented history of sciatica. Premature closure. The initial impression was accepted without a distal vascular exam. And the triage note documented the objective finding, a purple foot that the treating provider never read. The chart had the information. Nobody acted on it.
This goes back to what we've been saying about documentation. When the triage note is documenting one thing and the provider note is documenting something entirely different, that tells the jury that the disease process was present and recognizable. and somebody did not examine for it, the whole system has failed when the document is showing a concern, but the providers and nurses are not communicating about it. That is nearly impossible to defend at trial.
In Illinois, a case that went to verdict for approximately $32.75 million involved a 26-year-old man with ulcerative colitis and a prior pulmonary embolism who had recently been discontinued from anticoagulation. He presented with atraumatic foot pain. He was seen at an urgent care center, an emergency department, a primary care office, and by an orthopedist, and was hospitalized with a diagnosis of cellulitis. Before an arterial Doppler finally revealed popliteal artery occlusion with no flow below the proximal third of the leg. Below-knee amputation was required. 5 different providers across multiple settings documented intact pulses and neurovascularly intact in a limb with documented arterial occlusion. No provider ordered an ankle brachial index or arterial imaging. The hypercoagulable state was never integrated into the differential.
5 providers, multiple settings. Every one of them inherited the prior diagnosis and carried it forward. That's diagnostic momentum operating across an entire healthcare system.
Hodgdodge versus Elkhart Emergency Physicians, Indiana, 2024. A 72-year-old man presented to the emergency department with severe right leg pain. The workup pursued deep vein thrombosis. Venous Doppler was ordered and returned negative. The patient was discharged. He returned hours later with a cold, discolored limb. CT angiography showed multiple arterial occlusions. Above-knee amputation followed. The jury returned a verdict of $11.2 million.
The venous-only pathway.
That case is the archetype of the diagnostic error Paul described. Negative venous imaging interpreted as ruling out the vascular complaint when it cannot exclude arterial pathology. The largest verdict identified in the research is Svamaney versus Ryan, Rhode Island, 2018, $62 million. A 55-year-old man with a known genetic clotting disorder was instructed by his physicians to stop anticoagulation for testing preparation. After 17 days without blood thinners, he developed massive clotting and gangrene requiring right leg amputation. Additional cases include a $15 million verdict in Illinois for bilateral below-knee amputation after 3 missed emergency department presentations, where only venous Doppler was ordered, and a $10.5 million verdict in Wyoming, where acute limb ischemia was misdiagnosed as complications of diabetes and peripheral vascular disease.
I want to expand on something here because this is an important teaching point. Critical limb ischemia from an embolicum process is not the only presentation we should be thinking about. Patients with increased risk of thromboembolic events, whether from endocarditis, hypercoagulable states, atrial fibrillation, or any prothrombotic condition, can present with emboli to any arterial bed. That means acute mesenteric ischemia, acute hepatic injury, stroke, upper extremity ischemia. The principle is the same. When you have a patient with known risk factors for thromboembolic disease, your index of suspicion for embolic phenomena needs to be elevated across the board, not just for the limbs.
What's the aggregate picture?
A Westlaw analysis of 547 amputation-related malpractice cases from 1983 to 2024 found that limb ischemia was the second most common reason for litigation, 154 cases, representing 28% of the total, trailing only infection. The average indemnity payment across all amputation cases was $2.3 million. Amputations caused by vascular disease were more likely to result in plaintiff verdicts. The CRECO Comparative Benchmarking System, the largest malpractice database in the United States, representing 28.7% of all claims, analyzed over 11,500 diagnostic error cases from 2006 to 2015 and found that vascular events, infections, and cancers accounted for 74.1% of all serious misdiagnosis-related harms. 89% of those claims involved failures of clinical judgment. Total payouts exceeded $1.8 billion over the decade.
Sarah, how do plaintiff attorneys build these cases?
The framework is consistent across the cases we've reviewed. There are 3 elements, and they map directly to the cognitive error cascade. First, the breach. Standard of care requires a complete vascular assessment of any extremity with symptoms suggesting ischemia. When the chart documents behavior instead of vascular findings, when there's no pulse check, no Doppler, no ABI, that absence is the breach. The plaintiff's expert testifies that a reasonably competent physician would have performed and documented a distal vascular exam. The defendant's chart becomes the evidence of breach. Second, the chart language. When the note says drug seeking, when behavioral labels replace clinical assessment, that language becomes the centerpiece of the plaintiff's narrative. It transforms a diagnostic error into a bias story. Plaintiff attorneys understand that juries process bias narratives intuitively. Jurors don't need medical training to understand that a physician who writes drug seeking, instead of checking a pulse, made a decision that was shaped by who the patient was, rather than what was happening to the patient's limb.
And this is where the documentation lesson is so important for the physicians listening to this. Drug seeking in the chart is not a diagnosis. It's not a clinical finding. It's a judgment about the patient's motivation. And in the courtroom, it reads as evidence that the physician's reasoning was contaminated by bias rather than guided by clinical data.
Third, causation. The ischemia window provides the causal timeline. The plaintiff's vascular surgery expert testifies that the limb was viable at the time of the initial presentation. Rutherford Category 1 or Early Category 2. Earlier diagnosis, even hours earlier, would more likely than not have led to successful revascularization or at minimum a less proximal level of amputation. Under the Rigwall 2 framework that's increasingly adopted, the plaintiff need only show that the breach increased the risk of harm and that the harm occurred. The defense cannot defeat the claim simply by arguing that causation testimony is too vague. This is a significant shift. It lowers the evidentiary bar for plaintiffs in causation arguments.
What about the defense side? What arguments are available?
There are several established defense frameworks, but each has limitations in this specific clinical context. The atypical presentation defense. The argument that the disease presented in an unusual way that a reasonable clinician would not have recognized. This defense is strongest when the clinical presentation genuinely lacked classic features, but it weakens substantially when objective findings were present but unexamined. If the foot was cool and pulseless, and the chart doesn't reflect that anyone checked, the atypical presentation argument collapses. You can't claim the presentation was misleading if you didn't assess it. The error in judgment defense, the argument that the physician made a reasonable clinical decision that proved incorrect, distinguishable from negligence. This defense fails when the exam wasn't performed. You cannot exercise clinical judgment about findings you didn't collect. A judgment call requires data. If the data was never gathered, there was no judgment to defend. Comparative or contributory negligence. Patient factors, such as failure to follow up, active substance use, or failure to disclose history. In some jurisdictions, this can reduce damages. But it does not excuse the failure to perform a standard physical examination. The patient's behavior does not relieve the physician of the obligation to examine the painful extremity. And the inevitability defense, the argument that the limb was unsalvageable by the time the patient presented. This was explicitly litigated in Chestnut v. United States in the Sixth Circuit in 2021. The appellate court criticized the trial court's causation analysis and ruled that matter of degrees arguments are valid, even if total salvage was not possible. Reducing the level of amputation is a cognizable harm. The inevitability defense fails when the plaintiff can show through expert testimony that earlier intervention would more likely than not have changed the outcome, even if the change is from above knee to below knee amputation.
The defense position is weakest across all of these cases when 3 things are present in the record. First, objective vascular findings were either documented but not acted upon or were never assessed. Second, imaging was either not ordered or ordered on the wrong pathway in venous rather than arterial. Third, the patient returned with the same or worsening symptoms, and the prior diagnosis was accepted without reevaluation. When all 3 of those are present, the plaintiff's case writes itself.
Paul, This is the second consecutive episode of the cognitive autopsy involving a patient with intravenous drug use, where attribution bias contributed to a misdiagnosis. The previous episode focused on epidural abscess. Is that coincidence?
It's not. These two episodes are paired deliberately. The cognitive trap is the same. The social history is the same. What changes is the organ at risk. In the epidural abscess episode, the patient presented with back pain. The IVDU label triggered the same cascade by which attribution bias, premature closure, diagnostic momentum. The spinal emergency was missed because the provider attributed the symptoms to drug-seeking, withdrawal, or a benign spinal process such as muscle sprain or sciatica, rather than evaluating them on clinical merit. In today's episode, the patient presents with leg pain. Same label, same cascade, different organ. The principle I want you to carry from both episodes is the same. The social history that makes you skeptical is the social history that elevates the pretest probability. IV drug use increases the risk of epidural abscess, and it increases the risk of endocarditis with embolic complications. The frequent flyer label should trigger vigilance, not dismissal. And there's a case in the research that bridges both episodes. A patient with repeated ED visits labeled as drug-seeking, with a clean toxicology screen, was ultimately diagnosed with a spinal abscess only after irreversible damage had occurred. The diagnostic overshadowing was explicit. The substance use label prevented the ordering of an MRI until it was too late. The same cognitive mechanism produces the same outcome whether the target is the spine or the limb.
Paul, this is the section our listeners tell us matters most. The one thing.
The one thing is this: every pain complaint deserves a focused physical exam of the painful area, regardless of the patient's history, regardless of their reputation, regardless of their behavior, regardless of what the chart says about why they came in. The chart should document what you found, not what you assumed about why they're there. Let me give you 5 concrete actions for your next shift. First, the 90-second vascular exam. For any patient with acute limb pain, palpate pulses, assess temperature, assess color, assess capillary refill, test sensation, test motor function. Document each finding explicitly. If pulses are equivocal, use bedside Doppler and measure an ankle brachial index. An ABI less than 0.9 is abnormal. Less than 0.4 suggests critical ischemia. This is a 90-second assessment, and it eliminates the most common failure point in missed limb ischemia litigation. Second, the diagnostic timeout before discharge. Before you discharge any patient with unexplained limb pain, ask yourself one question: have I considered and excluded arterial pathology? If you can't answer that based on the exam you've already performed, you are not done. Third, but separate behavior from assessment in the chart. If medication-seeking behavior is clinically relevant, document it using objective observations, PDMP results, specific behaviors you observed, discrepancies in the history. Put it in a behavioral note. But the clinical assessment, the impression, the medical decision-making, should reflect what you found on exam and what diagnoses you considered and excluded, not what you assumed about the patient's motivations. Fourth, treat every return visit as a new clinical event. If a patient comes back with the same limb complaint, the prior diagnosis is a hypothesis to test, not a conclusion to confirm. Re-examine from first principles. Document that you reconsidered the differential. A return visit with the same or worsening symptoms is, by definition, evidence that the original diagnosis may be wrong. Fifth, remember the inversion. The social history that triggers your skepticism is the same social history that elevates the pretest probability of the very diagnoses you're at risk of missing. IV drug use means endocarditis risk, which means embolic risk, which means arterial occlusion risk. When you hear frequent flyer, reframe it. This patient may be telling you something is wrong. Maybe they can't articulate it clearly. Maybe their behavior makes it hard to hear, but the limb is telling you to, if you look.
Paul, beyond individual clinician actions, are there system-level changes that could interrupt this cascade?
There are 4 that the research supports. First, structured triage vascular assessment. For any acute limb complaint, a pulse check and bedside Doppler, if equivocal, built into the triage protocol regardless of perceived etiology. This addresses step 1 of the cascade. If the pulse assessment happens at triage before the label shapes the diagnostic frame, you've created an objective data point that's hard to ignore. Second, institutional chart language standards. The evidence from Godou's randomized trial is clear. Stigmatizing language in the chart degrades the next provider's clinical reasoning. Institutions should develop and enforce standards that separate objective behavioral observations from clinical assessment and that eliminate pejorative labels as diagnostic impressions. Third, mandatory arterial imaging protocols for persistent or worsening limb pain without a confirmed alternative diagnosis, particularly in patients with risk factors for non-atherosclerotic arterial disease, including endocarditis, hypercoagulable states, and intravenous drug use. A negative venous ultrasound should not close the case when arterial pathology has not been excluded. Fourth, and this is the one I care about most, knowledge-based education. Mamede and colleagues published a study in 2020 showing that teaching physicians the specific clinical features that discriminate between acute limb ischemia and its common mimics, cellulitis, DVT, musculoskeletal injury, was significantly more effective at improving diagnostic accuracy than generic debiasing education. Accuracy improved from 24% to 40% on biased cases. That's a meaningful effect size from a targeted educational intervention. Generic advice to slow down and think doesn't work because the problem isn't speed, it's cognitive processing. Teaching the specific discriminating features creates a durable pattern that competes with the anchoring bias. This episode is an attempt to be that kind of education. I want to close with something honest. Taking care of patients who present repeatedly to the emergency department with pain complaints and histories of substance use can be difficult. It is cognitively demanding. It is emotionally taxing. The behaviors are real, and the agitation, the demands, the escalation, the system pressures are real in the overcrowded department, the limited time, the cognitive fatigue. We are not here to say any of that is simple. But the physical exam is not negotiable. The pulse check is not a courtesy. When a patient tells you their leg hurts, the limb has a story to tell. And that story does not depend on who the patient is or what the chart says about them. A cold, pulseless foot in a frequent flyer is the same emergency as a cold, pulseless foot in a marathon runner. The biology is identical. The standard of care is identical. The salvage window is identical. The only thing that changes is whether you look. Next shift: acute limb pain, any patient, check the pulse, document what you find. That is the one thing.
This has been the Cognitive Autopsy. I'm Brian. If this episode changes how you examine one patient, it was worth making. If you listen to our companion episode on epidural abscess in the IV drug user, you heard the same cognitive trap play out in a different organ system. If you haven't, we'd encourage you to. These 2 episodes are designed to be heard together. Thank you for listening. This episode is for educational purposes only. It does not constitute legal advice or medical advice. The clinical scenarios described are composites drawn from publicly available malpractice litigation records and medical literature. No individual patient, physician, or institution is identified or intended to be identified. Consult your own legal counsel and clinical guidelines for decisions affecting patient care or legal matters.